Okay, in 2017, 2018, when we did that, we didn't take individual disease condition or state. We just looked at mental health in totality to the rest of the budget. And like I said, if they started off with 0.5, and then we saw an improvement in 2016, 1.16, it was better than 0.5. But you're right. Probably a lot of the others are also not doing well. A lot of money is going into tertiary care. Not that it's not important; it's very important. But why don't you? I have a story in public health whereby you have a level ground and then you have a hole. So someone comes and says, "So how do you travel from A to B?" He says, "Oh, well." Whenever they fall into the hole, we put a ladder in and then they climb up and go to the next side. So public health, a brilliant public health guy comes and says, "Why do you want them to fall and then you give them the ladder? Why don't you put the ladder right across?" Yes. Thank you, that's public health. Clinical medicine, you fall, you get sick, we'll treat you. You get sick, we'll treat you. You get sick, we'll treat you. Please let us change. And I think that model also makes us doctors feel important because unfortunately, I mean, that's my view. So the answer to your question is yes, and I think the other clinical areas are benefiting, and mental health is seen as important, but how do we say it's important but not well funded?
It's important, but we fail to convince the community that we can do anything useful about it. And today we speak about the 20 million mentally ill people. What does that mean? That doesn't only mean that there are many people mentally ill, but also that we are unable to treat them well. That we are not as efficient as cardiologists and others who are with this miraculous treatment. If you look at how cardiology go up in resources, it went up in resources when it started doing silly things like replacing hearts. Then they said it's a miracle, this is a fantastic discipline. We have to give them more money. And in psychiatry, we have unfortunately failed to convince people that we are effective. Because most of the patients who we have, they hide themselves and they are treated well, they disappear, they don't bear witness to the excellence of treatment on one hand, and the others who are not getting well, they are seen by everybody and shown by people. So I think we also one way of getting more money is to show that we are successful. Exactly. If you promote what's called lipstick, you're not going to say many women have bad lips. You're going to say I have a wonderful lips. Never mind what the current state of the lips are. And the lipstick which works. In the same way, we should say not how difficult mental illness is, but how effective we are, how much we can do. And have people who have mental illness come along and say, if you can convince them to help us witness the success.
Prof, I agree with that notion. I think we haven't been able to convince people that community mental health is the way to go. Why? Because sometimes I see people on the streets mentally ill, obviously. Either they are almost naked, and I say to myself, if they had money or they had other resources, don't you think the families would take care of them, even when they have mental? So we as a community, just disregard our own people the moment they go mental, and all of us go mental one point in our life. All of us.
Well, you mentioned people who are going home. At present, in the whole world, there is not a single guideline which would say what must be the minimum capacity of a family to accept a mentally ill person. Yeah. A family which has a woman, for example, who has to look after a family and also a demented grandfather, can she accept another person with schizophrenia in her care? No. Yeah. But nobody has written down the minimal strengths of the family to be able to accept somebody is as follows. Unless if it doesn't have that much, you have to give them resources. In Italy, they've been giving families money. They say, "Now, right now we're looking after these patients. The average price per day in hospital is 250. We'll give you 25." And family says, "That's fine, okay, we can manage that." And they have in fact, particularly when they are poor family, see this is a major. But then there was a difficulty that they could set for the patient because he was the main person.
Prof, the other thing that we also have to look at is the stigma and discrimination. Yes. Even when they want to look at it, I come from Ghana, and we have a proverb that says that if you are going to marry, check the family background. If there's mental illness, don't go there. So that statement alone means, oh, this person has mental, within our family, let's put him, in a village somewhere so that nobody will see it. So that statement, we also have to tackle the stigma and discrimination. Otherwise, if you're going around in circles, families will not be prepared to take them out.
Tomorrow you will have a time to listen to this stigma presentation.
Yeah, I know. Exactly. The webinar.
And what you say, absolutely true. Stigma is our main.
Even before that, we need to convince them that problems we're having are real problems, and that they need to come to us. Because how we said that the so-called 60% of mild people are you and I, but there's a very subtle difference in that 60% that I need to seek help, and just us who have momentary instantaneous breakdowns, and like support at home would be fine, but then there's still very many people who need to learn. We need to teach them that they should discern when to seek professional.
You're a medical student or nursing student? Medical student. Prof, just one last story and then I'll leave. In medical school, we're going to have an exam in pathology. So an external examiner was coming, and we knew that the exam was in 2 months' time. And then we woke up one day, they said, "So the external examiner is coming in 2 weeks." I had diarrhea continuously for a week. I think for me, it was a mental issue because I hadn't read it, and I said, "Oh, 2 months, I have time." Yeah. So I think we need to make sure that all of us go through that phase, and we need to accept that, remove that stigma, so that people can talk. That 67% can talk about it, and as Prof said, the family can also say, "Okay, yes, we are going to help you, go through it, and not shun you because it's stigmatized."
Thank you very, very much.
Well, thanks so much.
Thank you. Well, I feel I've been second.
I didn't ask my co-presenter whether you have any comments to add to what I said. Sorry about that.
I just wanted to add just something very small to what Mina had asked. I feel like it's more of a no-brainer kind of question when you look at funding that goes to programs like malaria, HIV, TB, not only that we have to take a more national ownership and put more money there because the donor funding is being decreased. So you will see a big gap in between the budget, both externally and from government sources, that will still be going to these programs as of now. And we're still not getting the traction in terms of putting resources towards mental health and other
question. Yes, sir. I've been diagnosed with bipolar disorder for 20 years, bipolar 1. And I would like to ask about the holistic approach to mental health because I feel as if medication is just a plaster, and we have to look at physical health, we have to look at more group support, we need to look at right now the patient local doctors tremendous, and we need to look at how the doctors can actually go deeper than just prescribing medication is better.
I totally agree with you. I have no other comment to add.
There's one other comment which is very important, and that is that in thinking about how to construct a service, people who experience mental illness financially have been allowed to say what is for them important, not only which medication, whether the medication makes them sleepy or not. But also a little bit about organization services, or placement of services, what they appreciate in the doctor, what they don't appreciate. And that's a gradual process, which I think can be very helpful. Also in building services. People who are evangelists very often are amazingly tolerant of what happens. We've done a study in 17 countries. If you ask people when they are leaving the hospital, how was it? And what do you feel? And they practically all of them who left the hospital said it was fine. So, and they're very happy. So we asked them on that, how was it? Tell us a little bit. And the food okay. He said, well, there was a whole range of bad things. One bad thing that came out was that they were beaten by snakes while they were in the hospital. So our investigators would ask them, how can you say that the treatment was fine when they were beating you with hospital snakes? Well, we don't know whether this was necessary. For us, it was important that we recovered at the end. In many of our studies, we've done this error that they have not talked about the course of illness, but just about the outcome of illness. Maybe the outcome of illness is not so splendid, but living with the misery is also a condition which we have to keep in mind. That's something that we have to keep in mind. Yes.
I have a question from the other side. So we understand that Guyana is number 2 in the suicide rate, and the budget for the healthcare is really small. Now, let's flip the coin and say, what is the lowest suicide rate, and moving down that path? What do they do right that doesn't cost anything that can be adapted into Guyana healthcare?
I think that's a very good point, and that's something that I'll leave for you others to research for us. I think it's a very, like I said, it's a very good point. In a resource poor setting, we may definitely have to look at things like that. And I think, Rosalie, we will benefit from your insights if you know of any such ones that you can share with us, or maybe Prof as well, if you can share some of these with us that we can adapt at virtually very little cost. I think probably that's the way to go. And also one other caveat, I do not, but I did not have enough time to look at the data in terms of funding for 2022 for mental health. Because I'd love to see that as well. I wrote to mental health unit, I wanted to know how much they were given, and I know the government for help, so that I would have calculated it, but I didn't receive any response. But it's something that I would love to find out, because the 1.16, they have moved a little bit to maybe 1.62. 1.162.
Dramatic issue. This charger decreases of suicide rates that have been done, which we know about. For example, when Gorbachev came in power and forbade the drinking of alcohol in all places at very low prices, suicide rate went down like that. It was quite clear that the availability and a lot of drinking contributed to suicide rate. So there are some things which we know about this, and I think that the study of low suicide rates, which are very complex, much more complex than the high suicide rates, I think are probably contributing. I think we have to thank you very much. If you can stay with us, we will be delighted. If you have to go, we will regret it.
No.
Okay. So I think that our second point will be a presentation of the ways in which the 1930 Guyana Mental Health Ordinance was revised.